All right, well, good afternoon. Welcome everybody to University School's presentation with Dr. McElligott from the Center of Telehealth at MUSC about updates in telemedicine. Here we are during the middle of the COVID-19 pandemic, and University School, would normally on a Wednesday be going on a field trip, and every December we go to MUSC, and we met Dr. McElligott in 2013 and enjoyed hearing this wow moment about how you could see patients remotely and what future that held for all of us, and to watch how that's really exploded at MUSC and has proved to be so vital here during the coronavirus time. So we appreciate his coming and giving us an update and sharing insights with us, and it's just very generous with his time. So Dr. McElligott, I'm going to turn it over to you, and we're very grateful. Thank you.
All right, I'll try to flip to share my screen here. So make sure that happens for me, okay? But I will say, oh, it's making me correct my preferences. I apologize. Let's see, hopefully this will do okay. I was going to say, I'm always nervous talking to folks your age, because you probably should be like, duh, this is obvious. Why do people have to go see the doctor at all anymore? And I think you should keep thinking that. So I think you should keep asking those questions to go forward. I'll try to touch on why this is so difficult sometimes in the era of Uber and all those other kind of things. But I think it's actually demand from professionals and from citizens and patients alike that will change the tide. So can you see my PowerPoint now? You can?
Yeah, it looks great.
Okay, good. I will go to this view. So some of my, I took some of these slides and put them together. What I thought I would go over pretty quickly in just the 30-minute period here is, a report that we have together about the status of things for last year. But some of it is actually fairly, I won't call it irrelevant, but things have changed so much because of the current coronavirus situation. So these are two investigators I'd like to acknowledge, Dr. D. Ford and Dr. Catherine Kring. I work very closely with in here listed on this. So I just thought I'd leave them on there to give them that shout out. But let me just do a cut.
Transform care. Why do we have a need?
Oh my goodness. Let me stop doing.
Well, there are many reasons. One of them.
Let me stop sharing this. It actually has recorded information in there. I wonder if I could do this.
Geographical disparities in access to.
You guys could hear me talking twice. That's what I'll do. I'll just let this play as a, and then I won't have to talk. Can you guys see my slides still? Doing it this way?
No.
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 Let me share this again. Let me share it again. It's gonna work, I promise. How about that?
That's good. Yep.
All right, we're gonna do it this way so you don't hear my overview recording from some other talk I gave. So anyway, just real quickly, so why do we need to transform care? Why do we need these kind of things? And it may be obvious to many people, but right here you see in front of you is a map of South Carolina, and the blue areas there are health professional shortage areas. So those are areas deemed to not have enough doctors and nurse practitioners and physician assistants to take care of patients. So you can see most of our state falls into that. The other part is that that as our country is aging, so as people, as the percentage of the population is older, the healthcare demands on the healthcare system increase. So we all get old and we all get sick in some way at times, and that's just going to happen at a higher and higher rate as sort of generations are aging and the population is shifting to and we're all living longer, which is great. But we also have healthcare demands that'll put a strain on the system. So some of these projected shortages you can see in front of you, but they're pretty stark. We look like if we don't do much different, it's going to be harder and harder to take care of ourselves from a healthcare system perspective. So enter novel ways of doing business have to occur, and telehealth is one of those. There's a lot of different definitions for telemedicine and telehealth, but this is a South Carolina definition that's written into our state law. And basically all the definitions basically say that you're trying to take care of patients over distance using distance technologies. So not too much rocket science in that, but it could mean anything from texting to video to toucans on a string, perhaps. I'm not sure, but there's a lot of app-based approaches. It's a pretty broad definition. It's been increasing year over year. It's been increasing for a long time, but as you can see that the last 3 years or 4 years or so, things have really been picking up. I'll tell you that these numbers are still a small percentage of the overall care you receive. Still tons of people mostly go to see the doctor in the normal way. But that has started to change pretty quickly. And again, this is all pre the coronavirus situation that we're in. So what's different about South Carolina? I won't try to do the animations on this, so I apologize about the slide. Well, in South Carolina, you know, over the years, I've been lucky to be involved with this initiative to bring more telehealth to our state. So I touched on how you all should keep thinking about ways that it's easier to care for yourselves and to work with your healthcare providers, to keep pushing on that as you become professionals. I think, so why is it hard? Well, healthcare is difficult because one, when you take an oath to be a doctor, for example, you're told to do no harm. And so you can never step in and do something different without making sure that you don't make things worse. And that may seem obvious, but you know, you take care of people over a distance, you got to be careful how do you do it. The other part, there's a lot of regulations. So your privacy is very important, and there's laws maintaining that occurs, that we have to maintain it. So anytime we open up technology, we have to make sure that all those privacy elements get extra scrutiny even then on your average technology approach, because it's healthcare. And really the third part is that the way that we get paid, healthcare is one of the most expensive things in our country that we do. We have great healthcare, but it's very costly. And so as we move things along, the way we get paid is built on a system where patients come in to see doctors and nurse practitioners and others directly in person. The payment models take a little while to shift, and that's been changing over the past, say, decade, but the technology is way out in front of the way you get paid. So it's hard to do business without getting paid. So in this case, what our state chose to do, and some states did, but our state, we should be proud of what we've done. They take some of your tax dollars and they route them to the Medical University of South Carolina, and we developed telehealth applications that were probably ahead of where the payment models are. So the way we distribute that across the state is called the South Carolina Telehealth Alliance. So other health systems in the state tap into some of those funds, and they get supported to find innovative ways to do healthcare. We are also designated as a center of excellence in the nation. We're one of two, us and Mississippi. To get this designation, you had to do a lot of telehealth. You had to be an academic center that could research that telehealth, and you had to be in a high needs state. Well, Mississippi and South Carolina are very rural, very high needs. We both happen to have strong telehealth shops. So we have this designation. So what that does is give us some federal dollars to help not only do more telehealth, but to study it. So we're a leader in the nation from that perspective. And last year we received this award that's on the screen. The American Telemedicine Association is the ATA. They give one of these awards out per year, and we received it for all the work we do. And they specifically gave us kudos for being collaborative in our state. So we're proud of ourselves. That's one reason to show you this slide. There's another reason to say is that this is a little bit of an artificial environment. So other people that don't have all this funding haven't been able to take as much risk and to develop as much telehealth as we have, because they had to do it basically in the way you get paid in the old system, if that makes sense. So without going into that too much, we've been doing this since about 2005, but you can see around 2014, 2013, we really got started when you all came by to see us. We were designated that Center of Excellence in 2017 and won our award last year. And then we'll see where we go from here. So in our state, there is, this is one of the most prominent uses of telehealth. This is telestroke. And I left out an overview slide, I apologize, but what this type of telehealth is video-based, connecting one hospital to another. So we have a lot of stroke specialists here in Charleston, but the rest of the state does not. So when someone strokes in our state and they go to a local emergency room, they should go to the closest hospital, no matter how small. This doesn't have all the hospitals on it, but other partners like Prisma Health and McElligott Health, the big health systems in our state, are supported by us and have similar networks. Basically, just about every hospital in our state can tap into an expert neurologist really fast because of a video-based connection that also gets your radiology, gets your CT scans beamed up and all the information that they need. And what you see here is we've done some research to show that if you, early on, before this was everywhere, we showed that if you lived in one of these areas with this, that you had a higher rate of receiving TPA. That's the clot busting therapy that saves you in a stroke, hopefully, if it's the right type of stroke, and that you almost had a 10% greater chance of surviving just by living in an area with this program. So it's really important to have this out there. The other thing that the program has done, we've created sort of the partnership areas where you still use your local healthcare system. And what this shows is we partner with McLeod, which is a big health system up in the Florence area. And the more that they call MUSC for support, the less they transfer. That's really important because in other health systems, they often have empty beds to be used, whereas places like MUSC are almost always full. And so you want patients to safely stay in their local community. It's less costly. MUSC costs a lot to be there because we have lots of different physical therapists and different kind of people to help you out. So it's an expensive place to be. You don't want to be there necessarily unless you're sick enough. Of course, MUSC wants the business, but if we're full all the time, we want the right business. So it makes the whole care system more efficient if patients can stay locally. And of course, if you're sick, and as long as you're safe, you probably want to be close to your house and your loved ones. So it's good to see that happening. I'm just going to breeze through a couple of modalities because I want to get into the coronavirus stuff pretty quickly, but I'll let you know, this has started the hospital-based approaches. A different type of way of supporting a hospital is 24/7 monitoring. So what you see here is in ICU teams, the sickest patients in the hospital are in the intensive care unit. And this is actually Dr. D. Ford there monitoring up to 150 patients at a time, in addition to the local bedside team. So what she does is she uses special algorithm type software that's embedded into the monitors at the bedside and beam up to her. And they use these algorithms to say, hey, the patient isn't doing so well, deteriorating. She can zoom into that, no pun intended, she can zoom right into that, where that patient is, see how they're doing, look at all their monitors and vital signs, check their records, see what's going, communicate with the local doctors and nurses. And they can even handle emergencies. There's a red button on the wall that she can help and guide a code and things like that. So it's an amazing program. It's also amazingly expensive. But so it is in around 10 to 15% of hospitals nationwide. But in smaller, poorer states like ours, it's not usually, don't usually find it. So because of our support and our partnerships that we've done, we cover a good chunk of the Southeast, South Carolina with this program, and we help hospitals. This program's data shows that if you say the expected amount of people that would die in an ICU, which there is a certain amount you'd expect to die, versus what we actually see, looks like the program saves between 150 and 200 lives every year. So this is pivoting now to the outpatient setting. So a lot of rural primary care practices can't have access to, say, a mental health professional or a registered dietitian. You see one of our dietitians on the screen there talking to a patient. And so what we do is we simply use some secure video approaches to talk and beam in resources into a local primary care office in rural areas. We probably do about 2,000 to 2,500 of these consults a year now. And the two most popular programs are registered dietitians to help with weight management and psychiatry support to get advice on how to handle patients that may need medication adjustments or are having trouble with their mental health or behavioral health problem. This also importantly includes addiction problems that patients may have, which is an important resource. But it also supports pregnant women and all kinds of different things to help people get more resources in their setting. And this slide doesn't cross very well here, but the point of this is to show that, where the dietitians are typically in the urban regions of our state, where the need is, where the red and yellow is there, where there's a lot of need for dietitians for weight problems, isn't actually not in the urban areas as much. So even though we all could use a dietitian, I think, every day, there's a mismatch between the resource and where it's needed, and this program helps to take care of that. So just quickly jumping through, we went from the hospital to the clinic, and now we're moving out to a community setting, trying to get care to local communities. So what you see here is school-based telehealth. We have one of our school nurses there working with a nurse practitioner in Charleston, and they are taking care of a child. In this case, they're using video-based approaches, and they're using electronic peripherals. So she has an electronic stethoscope so that the nurse practitioner on the other end can hear what they're hearing. We have special cameras to look in ears, to look up close at your skin and see the back of your throat, and do a number of other things. So this type of program has made a big impact in our state as well. We did a study that showed in Williamsburg County, it was the first county we went into, and for the next 3 years, we actually were not in the counties all around it. So it gave us a good control population, we would say. So we could measure what happened in the counties all around Williamsburg County, one of our most rural counties. And in that county, we covered every school. Every single school had this service, and we made sure that we did everything we could to make the program effective. We had some asthma camps. We did a lot of things to increase the awareness of this. So we were monitoring this program's impact on asthma. And over that 3-year period, compared to the other counties around it, Williamsburg County saw a 22% reduction in children that were showing up at the emergency room. And actually by the 3rd year, this is on average across those 3 years, but every year it got better and better. By the 3rd year, we had about 35% of reduction in asthma visits. So it's showing that the kids were healthier in that area, and they were staying away from the emergency room and had better control of their chronic medical condition and asthma. So this is all great stuff to see. I think when I spoke to you all before, well, your peers before, we were planning a lot of this. It's really because of all the support we've had and being able to study what we've done, we've got really strong outcomes that this is working. But now we move into some of the most exciting places where we're just communicating directly with everyone, directly in their home, on their cell phones. And just to quickly go through this, there's a bunch of different ways of doing it. You know, you certainly have video-based approaches with your phone, but there's also the way that you can transmit asynchronous data, such as like this EKG or your blood sugar or your blood pressure. And also you can do symptom tracking or questionnaires and a lot of different ways that we can communicate with each other to help manage a patient and a population's health. So one of the bigger programs we do with this is diabetic remote patient monitoring. This particular program, where the monitoring actually occurs here in Charleston, most of the clinics that participate are out in other areas of the state. And this particular program had a big health disparities focus and really worked with federally qualified health centers, which are clinics that are charged with taking care of low-income patients, and free clinics. So some of the patients were at the highest risk patients that you would imagine. And so what they do is they send home a glucose monitoring device. So if you have diabetes, they test your blood sugar, and it beams up to our cloud. Our nurses in Charleston monitor how the patients are doing, and then they work with the local practice to change the medicines and work with the patient to improve their lifestyles. And so what we've seen is the diabetic condition improving pretty drastically when this program's involved. And it's nice to see that we're using this resource in Charleston, but also serving these rural areas with these programs. This is just a graph. What we're seeing here is A1Cs. A1Cs is a marker how well you're doing with diabetes. Lower is better. And you can see that these are free clinics for the most part that are in here. So patients who don't have a lot of resources went from being very out of control with their diabetes to in control with their diabetes. And it happened at every clinic that we have worked with. So I'm gonna pivot here and get into the coronavirus stuff. Again, I'm moving kind of fast, but I'd much rather hear what your questions are and what you all want to talk about. So in Charleston, you know, we do have a coronavirus situation. We are lucky that we are doing better than some other areas, especially for urban areas, but it is increasing, and you can see the growth here that's occurred over the last few weeks to a month. This is a graph of the pace of the growth. So it's a little bit confusing, but this isn't the total amount of visits. This is just how we're growing. What we'd like to see is this to be negative. We don't want any growth, but we are still in the middle of our crisis, and we're at a peak, and the peak is very flat, which is good. You heard term flatten the curve. Well, we've seemed to have done that here in Charleston, but we're not out of it, and it could come back and all kinds of things. So I'm really glad you're not hanging out with me in person still. But we are lucky, and luckier than the rest of the state in some ways. There's been more outbreaks in other places and things like that. So we're doing well from a social distancing effort, and MUSC and others have tried to do their part from a healthcare part. So I'm going to talk about what are we doing at MUSC that is leveraging telehealth. So there's really, there's more than this now as all of this matures, and I'll touch on a few extra things at the end. But here have been our big 5 approaches. 1, people aren't supposed to go in to see the doctor anymore, so we had to turn all our visits to video visits. 2, we did virtual visit screening, which means that we have a virtual visit platform where, say you have pink eye or something like that, you can rapidly get care by accessing this portal quickly. We turned that portal into something that would guide who needs to be screened for coronavirus, so that early on we could really quickly try to get a sense of who has it, and patients were very nervous. Everyone was very nervous. We could appropriately screen people, and when we had limited testing, especially at the beginning, we had to say, hey, you're not sick and you've never been exposed. Maybe just sit tight. Use the platform to do that. I'll talk a little bit about, after you're diagnosed with coronavirus, how we monitor you, like the diabetes program, but you're monitored because you're at risk because you have coronavirus. And then we did initiatives in the hospital to minimize the amount of times patients, providers and nurses have to go inside and outside a room with someone who's been exposed. And then importantly, we made sure that families who are separated from their loved ones because they're in isolation had ability to connect via video with their family. Many people have FaceTime and things like that, but a lot of these patients do not, and we help them do that. So this ambulatory clinic conversion, this is probably too much information for what I show you here. So let me just zoom on. We had to switch platforms. We were doing so much video that we busted at the seams and broke the amount of video capacity we had. And so we partnered with a company, Doxy.me, that is local here as well, to really scale up. And now we're spreading that all across the state. Not really promoting any one vendor, but they really have helped us out from a free point of view. They made sure that we could access it free during this crisis. So long story short is here. We were told that, let me see if I can get, so on the outpatient side, the visits dropped, patients stopped coming in by 70%. So if you had 100 patients coming in a day, it dropped all the way to 30. And you have all these doctors and all these nurses and all these different people working, and nobody was showing up, nobody was getting care, and it dropped like a cliff. And so what we were charged with doing is getting everybody back up to business safely. And that we were given the goal that we were to get back up to 80% operations. And I'll tell you, by using video, but I've never seen it done. So I didn't know if we could do that. To put it in a little bit of scope, MUSC does about 1.4 million patient visits a year. Before this type of video, I didn't mention this type of video, direct to patient video, very much in the previous slides, because we probably did, I could count on one hand how many times we did it a week. And so what that meant is they were asking us to go from several times a week to about 2,000 times a day is what we were supposed to do. And so everybody had to do it. Everybody had to get over their nervousness. We had to build workflows that applied to 3,000 different doctors. We're going to have to do it all of a sudden, and everything had to be spread out, and we had to do it fast. We are not the only health system that had to do this, but we would hope that we would be well positioned with the support that we had had previously. And so this is some of the things that I just talked about I'll kind of skip through because it's kind of confusing, and this is for some operational things. What this graph shows here is what happened across the country. What I just described is that all across the country, these are the outpatient visits they dropped. We dropped about 70% on average. People dropped about 55%. We actually dropped lower because we had an early infection in one of our big clinics, and they chose to close the whole clinic down early on, and we dropped very far down in terms of our how many patients were coming in. So what these different lines show here, and if I had animation, it's more, you can see each dot dropping and it's like a cliffhanger, but there you go, you got all the dots. This is, the different lines are how much it dropped by different region of the United States. So the South Atlantic is in that orange. Some places were real bad off, and the mountains, they weren't quite as bad off, but all the patients quit coming in. So the dots are what happened here at MUSC. we dropped like a cliff. All the business went away, all the patients quit coming in, and we dropped really low. And so then we had to climb back up. Because we had the ability to teach and to spread all this video clients out really quick, we climbed quicker and faster than than the average, and probably did better than most. So we were thanked for rescuing things to a degree, but you will see that we're not back up to zero. We're not back up to normal operations. This is a graph straight from an MUSC dashboard that just shows the blue is the in-person visits and the orange is the video visits. So 2/3 of the recovery here is video visits. And you can see the in-person visits. Well, you can imagine those bars are getting a little bit longer, a little bit taller. That's still very slow to come back. So if you took away the video visits, there would basically be a lot of trouble, one for patients, but also the MUSC is one of the biggest employers in the area, and they've had to lay off 900 people because of this system. So it has a big impact. If I didn't do my job, we would well, someone else would be doing my job probably at this stage. So I'll quickly go through. This is a really quick algorithm of how you go about direct to patient things. And what I would want to point here is we kind of covered a lot of this gamut. So what I'll say is when you're trying to reach out to people, it's a little harder than if they are coming to you. So what we see is a lot of times we use automated texting approaches, reach out and text people in a secure way and say, hey, you have a healthcare need. Sometimes we leverage your need coming in and we want to make the front door wide open. And then other times we will be prescribing something like an app or something specific to take care of you. So within the coronavirus situation, we had this platform where you could come, and if you had pink eye, you could get some medicine, and made it super easy to come in our front door. But what we turned that around into doing is guiding people to testing places and making sure they had symptoms that had been exposed and appropriate for testing. Because what we didn't want is people showing up at the front door of the emergency room, banging on the door, demanding a test, and spreading potentially their virus around more. So we had to set up these drive-through testing centers. We were one of the first in the country to do a drive-through testing center. And the only way at the beginning that you could actually get to do this is to do our virtual urgent platform. That caused us for another program like the other one, to do like 2,000 or 3,000 calls a day, when before this program was doing about 40 a day at the time. And so the volumes increased drastically. So we continue to use this tool now that there's some immunity testing that people want to do to see if they can go back to work. There's different types of testing. We continue to use this tool and try to pivot with the state of the pandemic that we're in to try to be useful. And so it's still very busy. Now, again, to put you in a little bit of context, we had to hire, I think, 200 additional healthcare providers, nurse practitioners, doctors, and physician assistants to staff this basically overnight, because that's how busy we got. Anyway, so once you move through some of these things and you see some of the big volumes that were occurred, and not only receiving here, but we were serving across the state, we moved, if you were diagnosed with coronavirus, but you weren't sick enough to be in the hospital, you were discharged, we enrolled you in a remote patient monitoring program, or at least offered it to you. And what you see here is a bit of a dashboard that a nurse might be looking at. This is test patients, so they're not real. We didn't have a lot of 3-year-olds or anything in there, but but they would be able to look and see patients in red might have symptoms. They're reporting that that they're feeling sick or short of breath, and we would zoom in on them and call them and see how they're doing, or do a video visit. And we were able to admit patients quicker if they were showing signs that they were becoming sicker. This type of program, thankfully, isn't as busy as some of the others, but we're probably monitoring between 150 and 200 people at a time in the program to make sure they're doing okay. It's being enhanced with home pulse oximetry to know how your oxygen levels are doing at home, and a number of other things. So here's some numbers on that program. These are a bit old, but they it's working. The program's seeing the patients it needs to see, and is moving along, and we're keeping some patients out of there. And I'll just wrap up here and to say, you can take it lightly to say, oh, it makes sense to do video outside the hospital door, room, or out. But if you know anything about the healthcare crisis that we're in, we are really low on masks. We are really low on things that protect people. Because of how bad the coronavirus has been in New York, because manufacturing in China is shut down, because if it did hit Charleston bad, we might not have enough resources and enough beds and all these kind of things. And also the healthcare providers, the nurses who have to be around all these patients, don't want to have to expose themselves unnecessarily. So what we did is set up video portals inside and outside the rooms, and they've been used several thousand times as well over the past few weeks to make sure that if a nurse doesn't have to go in and can talk to the patient from outside, they can do that, and they can keep themselves from being exposed too much. And this had to be very easy to clean and had to be very easy to use. And so that's why I put this kind of video unit up. And again, I'll skip through some of the things on here where we were setting these up. And we did similar things to connect families with their home, and we found out that that was a bigger deal than we had thought. And we connected a lot of families home, and we continue to do that when they're stuck in isolation. Otherwise, would be sitting in there by themselves and stressing about will they see their family again. It's a big thing. So I will just finish here to make sure we have plenty of time and see what kind of questions we have. But that's kind of a breeze overview of what we thought was important and still is last year in our annual report, and what has happened in the last few weeks that have really turned our world upside down.
Dr. McElligott, that was fascinating. My question for you is this: do you want to leave the screen share up so that you can refer back to it, or do you want to go to the gallery view? So
I probably the gallery view. You know, a lot of these are very operational slides I stole because I didn't have a whole lot of time to make it high school friendly. But I think you guys are pretty smart.
Yeah.
Let me see what I can do. Stop sharing.
There you go. So I'm going to ask you, if you've got questions, if you could use the participants hand raise button, and then you can queue up, and then we can give Dr. McElligott your questions, and I'll moderate and call on you. So think about your question, and then let's push them out.
Should I?
You have a question?
Sorry, I wasn't expecting it. Okay. Are you trying to make are you succeeding in making medicine? Like, are you trying to make a medicine for the COVID-19?
Well, what we're charged with doing is trying to use with what we have. So at MUSC, there is research going on to do different types of testing and different medicines. But I would say that's happening all across the country, that the best scientists in our country are trying to figure that out. So we just have a smaller role in that part, I would say, at MUSC.
Sorry to catch you off guard, Ensley. All right, Kessler.
Hi. Thank you so much for doing this. So I had a question. So most economists are, when we return back to normal life, a lot of the things that we do and the ways we approach things are going to be radically different, like shopping, your vet appointments. So like do you think its growth is going to be exponential, and like it's going to be implemented all across the country in places that it might not be after this is over?
Yeah, it's a really good question. You know, you could look at it a few ways. I might be out of a job because we just did everything and everybody uses telehealth and it's easy. I think the world doesn't know if they're going to allow us to keep doing this outside the crisis. If our president decides that the disaster's over, then a lot of the rules that we're operating under right now that allow us to do all of the telehealth I just described would go away. And so if we can't get paid to do the work this way, then no, the health system can't keep doing it. I will still try to do it from a strategic perspective and try to get to those patients that are most in need in rural areas or the sickest. So will we go back to it being normal business or not? Nobody really knows. I will tell you, some people who do this realize how easy it is to connect in. It's hard for me to imagine that we'll go back completely to where it was before. So I think the post-coronavirus world for the healthcare world will be different. I just can't predict what that means yet, but it'll be different in some way. And honestly, I hope that care becomes more what I would call patient-centric versus physician-centric. So if you think about it, in the old days, people used to do house calls, right? And we'd go and visit families. Now you have to go to the doctor's office because healthcare is so expensive. We had to line the patients up outside the door and make it so that the doctor just sits there and everybody comes to see them. But this is kind of taking it back to the old days. And I really hope we start keep taking care of patients in their home again. That's what we're doing right now.
All right, thank you for that question and that answer. Next question is by one of our guests, Lyneste.
And I'm just wondering about how you do monitoring for the at-risk populations.
Monitoring for people that are not diagnosed, but they're at risk.
Or people who may be symptomatic and possibly have COVID.
Right. Yeah. So what they're guided to do typically is to use that virtual urgent platform. If you have symptoms, you're supposed to go onto our platform. It's a series of questions you get asked, and then if it seems appropriate, and it's kind of wide open now because we have more testing, then it guides you to a test that asks you where you want to get tested, and then they send you into a safe place to get tested, like a drive-through testing center or something. So there's a lot of public marketing and push out to say that if you have, if you think you're sick or you have these symptoms, use this platform to help guide you to get tested. I'm not sure if that answers your question, but if you're out there, we don't necessarily proactively monitor you. We don't know who you are. I will say that some employers and other health systems are asking MUSC to help monitor their employees because they want them to come back to work, but they don't want them to be sick. So we are starting to kind of use some of these tools to kind of survey those populations.
Thank you. Kit, your question, please.
Hi, yes. Thank you for coming, first of all. But I was wondering, are there any, with the coronavirus coming up, were there any new sort of things about telehealth or like uses for the telehealth that you didn't consider before that sort of developed or emerged from the whole pandemic situation?
I'll tell you about one. It does. I will say, for the most part, what we've found is that what we have put in it was really underutilized, and that people just needed a reason to start using the tools. For the most part, we are lucky that we had all this stuff in place so we could put all these pieces together. It might seem straightforward to you all, but it took us years to develop them, and they were ready. So we were lucky to do that. I will tell you about something pretty cool that's happening. Apple and Google are actually working together. They're fierce competitors, but during this time they are. And so one of the things that we're not doing yet that we're beginning to figure out how to do it, we'll probably be tapping into what's happening with these national companies, is what's called contact tracing. So if you were to get sick, somebody from the health department is supposed to call you and say, who have you been hanging around? And call those people and make sure that they see if they're sick, and they try to figure out who could have been exposed and how do we contain this. And that's a typical thing you do with tuberculosis, what they used to do with smallpox in the old days and things like that, or the Ebola crisis, they would do those. The problem is with our current situation, this virus is spreading so fast and that you might not be able to keep up. And so what Google and Apple have done, you would have to give permission for this to happen, so don't freak out or anything, but your phones and your Bluetooth devices, once they roll this out, they will tell you who you've been standing near. So you walk through Walmart and say you were sick. If that person was also participating and they gave permissions, it would say, hey, yesterday you walked by somebody who's sick. And so they'll be able to use your phones and your Bluetooth technology to do contact tracing, and everybody will know that they were somehow exposed in the past week or so and can get checked or stay home or try not to get anybody else sick and contain it that way. So that's pretty novel. They're making a lot of efforts to make it not be spying on us, so they say.
That's a good question, Kit. Dr. McElligott, that reminds me of a 60-minute story from this weekend about how GM has been moving to make ventilators, and they are piloting a device that they wear on their wrist with the Bluetooth technology that if ever the one that you're wearing gets close to another person who's wearing it, it will vibrate or beep or say something. As we're trying to unwind all these years of civility and being close to each other, it says
Right.
back. So
Yeah, too close. No, there's these wearables and our phones are powerful devices that just starting to tap into, but appropriately they have to guard our safety and our privacy, and they're doing some pretty clever things to do that. So you wouldn't know who you passed in Walmart, and nobody could figure it out. You just know somehow they were positive, so you wouldn't know who it is, and nobody could figure it out. You just know that you were exposed. So it's an interesting thing. So. But yeah, there's a lot happening. I will say we're putting in a grant with some other companies to create a field hospital for with ventilators and to be for future pandemic. Probably it'll take us too long for this one. Hopefully this pandemic will go away, to be able to remotely pop up a very advanced hospital in a gymnasium and use some of these other technologies to take care of those kind of settings from afar. So we're learning a lot from this pandemic. I think next time around will be other places will be just as fast as us, and we'll be better at doing whatever that next iteration is. We're proud of ourselves though, and we should thank you all, because it's your tax dollars that helped us be ready. So, but our state did well.
Well, this presentation is important because as we meet every day virtually in the morning before we start our school day, and one thing we've learned, there's a lot of articles about astronauts a couple of weeks ago about learning about the thing that's causing you fear is one way of sort of owning it and reducing your anxiety. And knowing that we live in this town that has MUSC and you and all these different things going about, and that we're far ahead of this curve, it's should be reassuring to all of us. And I'll put in a plug. We did one of these 3 weeks ago where a third-year medical student at MUSC was demonstrating what the COVID screener looks like. And so he was sort of walking through it, so that you might be nervous to call MUSC because you're feeling sick. And he's like, oh, it's just a questionnaire. And he went right through it. And that's just owning it a little bit. It's designed to reduce your fear. So.
Right. Well, I wish we didn't have to use these tools this way, but the ability that we can get things done and never have to come close to each other, that's what it's all about. But in the future, I hope it's about keeping care more personal and centric, so that, it's super easy to get something checked or to take care of yourself. And again, become more patient centric. So we've learned a lot, and we're certainly going to take these lessons past the pandemic.
Can I ask you a question that someone asked in 2013, because I remember it because it was so profound, which was, how did you foresee feeling taking care of patients effectively and remotely and not having to get in your car and visit rural hospitals or rural schools, but not being able to be in the room with your patient? And sort of, what was that?
I will tell you, I think you all probably could answer that now that, this has been a good few years later since then, but I would say I didn't like telehealth up front, and I probably said this back then. I didn't do this because I like technology and I love visiting my patients. I did it. One, it was my interest was in health disparities and helping out. I'm a pediatrician, and helping out the kids that needed me the most. And one ear infection at a time didn't seem enough, right? That I needed to do more work. So went down this road, but I think, and that's why I can't handle Zoom video either. I'm not really actually good at this stuff. But I will say, people get married with online dating these days, and people do these calls. I think what was surprising is how human the connection is. Even that diabetes remote patient monitoring program I talked about. Sure, you get a glucose in your house, glucose sent up to a cloud, some nurse far away reads it, somebody, contacts you somehow. But it's that last piece, the contact somehow. Some of these patients are very lonely and by themselves in their home, and they're getting this call like daily from a nurse, and they build up a very human relationship. So I think we overestimate the in-person encounter. We underestimate how frequent encounters can really build a relationship. And so we have some of our school-based team, they show nurses sort of fist bumping with the patients, and we have pictures sent in from the kids that we serve in these rural areas. So I don't worry about the human element anymore. I think, but you have to, I think the thing that makes it better is, communicating more in a comfortable environment is better than seeing somebody once a year and pretending you know them.
This has been way better. This has been so great. I just thank you for sharing your time and to see how much things have changed over 7 years ago. And to be grateful that these tools are in place now. Imagine coronavirus 10 years ago when we didn't have telemedicine. It would have been, it would have been devastating.
Yeah, I don't even know.
Yeah. So kids, this is your chance to turn on your video, and we're gonna wave and say thanks to Dr. McElligott for being here today. It was a wonderful time and really helped all of us. So thank you, and thank you for being here today. You can unmute
Thank you.
and say goodbye, and that'll be it.
Thank you.